അതാണ് കാരണം ഇപ്പോൾ എല്ലാ മെഡിസിൻ്റെയും കൂടെ ഒരു കോ പ്രിസ്ക്രിപ്ഷനായിട്ട് ഈ PPIs വരുന്നുണ്ട്. PPIസിന് അതിൻ്റെതായ റോളുണ്ട്, പക്ഷേ അതിൻ്റെതായ ദോഷങ്ങളുണ്ട്. ലോങ് ടൈം കഴിക്കുമ്പോൾ പലപ്പോഴും PPI മുടങ്ങാതെ കഴിക്കുന്ന മാസങ്ങളോളം 6 മാസത്തോളം കഴിക്കുന്ന ആളുകൾ നമ്മൾ നമ്മുടെ പ്രാക്ടീസിൽ കാണാറുണ്ട്. അപ്പോൾ അതിനെക്കുറിച്ച് കൂടുതൽ പറയാനായിട്ട് ബിനോയ് ഇൻവൈറ്റ് ചെയ്യാണ്. ഡോക്ടർ സജേഷനും വെൽക്കം.
Yes.
Good evening.
Good evening. Hi, Sajesh. Good evening.
Hi, Dr. Benoy.
Long time.
Should we wait or we are starting now, Dr. Kamat? Start. Okay. Can I make the introduction so that we can start off the topic then? Others can keep joining. So, as Dr. Kamat was saying, as you all know, all of us are regularly using PPIs of different kinds, whatever molecules are there in the market. All of us use it for various treatments and prophylaxis. Also, we use it. And in recent years, there has been some reports about caution in the usage of PPIs, and they have been associated with pneumonia, some superinfection with Clostridium difficile, iron and B12, and magnesium deficiencies, hip fractures, worsening of CKDs, dementias, lot of other things. So I think this is a very apt topic today. It is of interest to everyone, whichever type of practice they are doing. And we have a very good speaker who has come for us. We are seeing him after a long time. It's a joy to see you over Zoom at least. And I welcome Dr. Benoy Sebastian, who has been working as a senior consultant gastroenterologist at Medical Trust Hospital. He did his MBBS and MD from Kottayam Medical College and his DM in gastroenterology from Trivandrum Medical College. And we are very happy to have you here. And we hope that this will be a very enlightening topic to us. Thank you. Over to you, Dr. Benoy.
Thank you, Dr. Sajesh. Respected President of IMA Muvattupuzha, Dr. Rabindranath Kamath, whom we fondly call Kametan, my close friend. Office Secretary Dr. Ali, other close friends, beloved friends. It's always a joy to be back in Muvattupuzha, as Sajesh said, at least in Zoom. So shall I start sharing my screen?
Sure.
Are they coming?
Yes, sir. Yes, sir.
Yeah, the title goes Proton Pump Inhibitors Use, Misuse, Abuse. As you all know, proton pump inhibitors are the drugs which inhibit proton pump. What is this proton pump? Proton pump is a pump which secretes acid, and they are situated in the gastric parietal cells. So this is the final common pathway of acid production. As you all know, the acid production is stimulated by various factors in the stomach. The most potent stimulant is gastrin. We are all familiar with histamine. The histamine is blocked by ranitidine. That's how it works. And acetylcholine also to an extent can stimulate acid production. But something which blocks all these three, gastrin, histamine, acetylcholine, the effects of all these three molecules act through the acid pump, the sodium, the hydrogen, potassium, ATPase pump is proton pump inhibitor. So this is the most potent acid suppressive agents as of now we have in the market. And the first drug, omeprazole, was introduced back in 1989. And then after we had, a host of molecules, lansoprazole, pantoprazole, rabeprazole, esomeprazole, and the latest bit is dexlansoprazole. And you're all familiar with these molecules, and I'm sure every doctor was attending the Zoom, or all practitioner doctors would have been writing at least half a dozen prescriptions of PPI every day. If you look into the pharmacokinetic characters, in fact, the bioavailability, half-life, metabolism, they're all almost same. And if you look into the clinical efficacy, all are more or less the same. Though there are minor differences in the pharmacology, the ultimate efficacy of PPAs are comparable. So how do they act? They are weak bases. And when you take the PPA, straight away goes to the duodenum without any damage in the stomach. That's the reason why we get the PPA as enteric-coated form or gelatin-coated form. So this is absorbed from the duodenum and reaches the parietal cells through the bloodstream. It's very important. So you should never break the PPA tablet. It has to be swallowed as such. And through the bloodstream, it reaches the parietal cells, and parietal cell canaliculae is very acidic. The pH is almost down to 2. And these bases will get concentrated in the acidic parietal cells, and there they undergo a process called protonation. After protonation, it becomes active. So till that time, it's a prodrug. So this active moiety forms irreversible covalent bonds with the cysteine residues in the hydrogen potassium ATPase pump. So these active molecules block the pump by forming an irreversible covalent bond. So the pump becomes totally inactive. So a putative duration of action is almost 24 hours. And we need another 18 to 24 hours for the new pumps to form and produce acid. So the mechanism of action, at least as per this mechanism, PPA once daily should suffice the purpose. The thing is, these PPAs will inhibit only the pumps which secretes acid. So in the fasting state, only 5% of the pumps are active. So when we eat food, the food gastrin simulates acid. So when the acid production is necessary, the pumps become active. So after a meal, around 60 to 70% of the pumps become active. So in order to get the maximum potency from a PPA, the molecule should be given 30 to 60 minutes before food. That's why we all insist that the drug should be taken before food, or you should eat something 30 to 60 minutes after taking the drug, because the drug has to reach the duodenum, and from the duodenum through the blood reaches the parietal cell. By that time, the pumps will become active if we take food. And generally, once a daily, OD dose is enough. And it is shown that up to 3 to 4 days of daily medication is required before the full acid inhibiting potential is reached. And similarly, once you stop the drug, it takes 3 to 4 days for the acid secretion to return back. The PPA, after inhibiting the parietal cells, undergo a rapid first-pass metabolism in the liver, and it has only very negligible renal clearance. So there is no need for any dose reduction in patients with renal insufficiency or even in mild to moderate liver disease. So what are the indications of PPA? As Dr. Kamath said, we almost always use PPA along with whatever drug which we prescribe. Is it really necessary? If you look into the indications are very limited. So probably can be classified into two: short-term treatment and long-term treatment or chronic treatment. For short-term treatment, it is used to treat ulcers, both gastric and duodenal ulcers. And this is the cornerstone of H. pylori eradication. As you all know, H. pylori is the one which produces ulcers. So we need a couple of bacteria along with a PPA to eradicate H. pylori. Then this is used to prevent stress ulcer formation in patients who are admitted in ICU with various acute illnesses. This is used on a short-term basis in dyspepsia. Now, those patients who come with an epigastric discomfort, they may be having gas, they may be having pain, they may be having bloating, they may be having a reflux type of dyspepsia. In such cases, on a short-term basis, you can use this drug. And chronic treatment in GERD, gastroesophageal reflux disease, this is the drug of choice. And GERD, as you all know, this is not like an ulcer. Ulcer, you give a finite therapy, the ulcer is healed, you can stop the treatment. But GERD is a continuous process. The reflux keeps on happening, particularly if there's hypercapnia. So in those situations, you may have to have a prolonged, acid suppression. Similarly, the drug is used along with NSAIDs in patients with ulcer risk factors, like previous history of peptic ulcer, previous history of a complication like a bleed, elderly people, concomitant use of aspirin, steroid, or anticoagulant. That doesn't mean that you have to use it along with the steroid. If you are using an NSAID plus steroid, then you have to give a PPA. Then another entity is eosinophilic esophagitis. This is an allergic response, but there is a subgroup of eosinophilic esophagitis which do respond to PPA. Then hypersecretory conditions like Solling-Rayleigh syndrome. So the question is, the interest of focus of today's discussion is, are we overusing PPA? This quote is an interesting quote which I came across when I did this searching. Doctors pour drugs of which they know little. To cure diseases of which they know less. into patients to film, they know nothing. Well, I think it holds true even now, because many a time we don't know what exactly we are dealing with. We often come across such cases where previously we used to put it as NYD, not a diagnosed. But you'll have to offer the patient something, or you'll have to have some provisional diagnosis. Based on that, you start some empirical treatment, and still we don't know whether this is going to benefit the patient or not. But that is the way medicine works. So if you look into US data, FDA has approved Proton the remedy for heartburn treatment. But look at the recommendation. The recommendation is very stringent. PPAs are only intended for a 14-day course, only for 3 times a year. So this is very stringent. You cannot use PPA more than this. But what is happening? If you look into the hospital data, if you look into the overprescription of medications from the US, they have found that PPAs are among the top 5 classes of our prescribed drugs. At least 60% of they use PPA without a proper indication. And in JAMA in 2012, another interesting article where they looked into the various overprescribed drugs, and PPA again fared in that list. And this is not only in US, various other countries, Australia, Europe, they all showed inappropriate prescription of proton pump inhibitors. And this is another interesting paper which was actually published in Journal of Public Health India. So this was titled as Medication Misuse in India, and they said it's a major public health issue. The interesting aspect was this particular observation. They actually used 115 articles, and they came to a conclusion that an observation that at least 50% of the medical expenses on an average Indian family is for unnecessary drugs. Well, I am sorry to say that I am, including all of us probably, are contributing to this 50%. Many a time we do unnecessary investigations. Many a time we make or rather prescribe unnecessary medication. So all these things are actually increasing the economic burden, the therapeutic cost, as well as probably put the patient at risk. So the question is, are PPAs safe? We all know about the common side effects like headache, diarrhea, constipation, abdominal cramps. They are in fact minor side effects. And if you search the Google long-term side effects of PPA, look at the number of hits. It is more than 33 lakhs in less than a second. Well, all of them may not be representing the side effects of PPA. Maybe a lot of other papers will come, but there is an abundance of literature. A lot of people are interested. A lot of research is going in this particular direction, and various titles. And if you look at the BMJ Open title, Risk of Death Among Users of Proton Pump Inhibitors, a longitudinal observational cohort study of United States veterans. So not only renal problems, not only cardiac problems, our doctor suggested, it also said that it can actually increase the all-cause mortality. So PPAs are dangerous. And this cartoon shows that it can in fact affect any organ in the body: heart, lung, brain, stomach, kidneys, bones. So if you look into the various side effects, I just try to classify them. So if you look into the gastrointestinal side effects, probably the most important and most relevant is development of pseudomembranous colitis. This picture actually shows colon, but you can see whitish plaque-like lesions. This is a typical appearance of a PMC colon produced by Clostridium difficile. And the classical teaching is that it happens, or this is otherwise called an antibiotic associated diarrhea, and a classical teaching, or we all believe that this happens in a patient who is on broad spectrum antibiotics on a long-term basis. Well, we are actually wrong. This can happen in a patient who has never received antibiotics. This can happen in patients who are hospitalized for a long time. It's not a mandatory that you have to be on antibiotic to get PMC, and PPA alone is set as a risk factor. Then there is a high risk for other enteric infections, and it can lead to something called small intestinal bacterial overgrowth. Why this is happening? Because PPAs, they do a benefit by suppressing the acid, and they do a lot of good in GERD because the acid production is suppressed. But when you do that, we are actually interfering with the normal hemostasis, normal physiological milieu in the gastric, in the stomach. The normal pH is acidic, and this acidic pH is important to kill all the microorganisms. So when there is hypochlorhydria, when the acid levels are low, many organisms which are actually trapped in the gastric acid pH will go into the small intestine, go into the duodenum, jejunum, large intestine, get colonized, multiply, and can produce diseases. So hypochlorhydria, or suppression of acid, is the mechanism which is proposed for development of dysenteric infection. In cirrhosis, cirrhosis, they have various problems, and of late we have observed that there is an increased risk of spontaneous bacterial peritonitis with PPI use. Again, probably add to the same principle. SBP happens because of increased bacterial translocation from the bowel through the lymphatics, which reaches the ascitic fluid. With SBP, it can precipitate renal dysfunction and hepatic encephalopathy. Though these things are there, so far there is no dose modification or routine use in cirrhosis. Gastric issues. Apart from suppression of acid, when there is suppression of acid, what the stomach does is to stimulate gastrin, because gastrin is the stimulant for acid. So more gastrin is produced. The gastrin will stimulate enterochromaffin-like cells in the stomach. These enterochromaffin-like cells, when there is a hyperproliferation, it leads to various neuroendocrine tumors like Carcinoid syndrome. So this is one of the first side effect or concerning effect noticed along with omeprazole in the early days, and at that time it was noticed only in rats. So far, there is no report of enterochromaffin-like cell hyperplasia or Carcinoid syndrome in humans. So theoretically, there is a risk of development of neuroendocrine tumors. Similarly, if there is an atrophic gastritis, hypochlorhydria, gastric atrophy, it can lead to carcinoma stomach, particularly in those patients with H. pylori infection. And as already mentioned, it can lead to deficiency of various minerals and vitamins like magnesium, calcium, iron, vitamin B12. All these things are because of hypochlorhydria. Acid is necessary for the absorption of various minerals and vitamins. Renal failure, both acute and chronic. In acute, it's thought that it's an idiopathic hypersensitivity reaction. So even a single dose of the PPI can produce an acute renal injury. It's an interstitial nephritis. So re-challenge has to be very careful. You are supposed not to re-challenge. Similarly, in chronic kidney disease, there is a multiple meta-analysis. Actually, the particular trial came in JAMA. There, PPI can actually produce CKD. It can worsen the course of CKD, as well as it can accelerate the course of CKD. The exact mechanism is not known. This is not like an AK. This is a chronic process. So, well, we still don't know why this is happening. And probably one of the blame game against PPI started with this particular paper, the interaction with the clopidogrel. So this is a landmark trial. I won't say it's a landmark trial, but this is a awakening trial, which alerted people about this interaction. So it came in JAMA 2019. This was a trial which was based on case sheet or hospital data, retrospective trial, where they included more than 8,000 patients spanning for 2 to 3 years. So they found that patients who got discharged from the hospital following a cardiac event, an acute MI, angina, or a cardiac procedure, many patients who were on PPI clopidogrel combination had a higher risk of death, as well as readmissions with further cardiac events. And later on, this particular study was criticized for many things. First of all, it's a case sheet based data. It's a retrospective data, not at all designed in a proper way, but it was an eye opener. And later it was discovered that this interaction happens because of the metabolism shared by clopidogrel and omeprazole in the cytochrome P450. So they share the same P450 system. Omeprazole is metabolized by the root. On the other hand, clopidogrel is a prodrug and actually needs this particular enzyme system to become active. So if omeprazole is competing with clopidogrel, then clopidogrel will become inactive, or rather clopidogrel will not be activated because of the lack of deficiency of this enzyme. So that's why even if you give clopidogrel, the active drug is not produced in the presence of omeprazole. And the maximum interaction, so they examined other PPIs as well, and they found that the maximum interaction is with omeprazole and esomeprazole, and there is very little interaction because pantoprazole has got another separate metabolic pathway. So interaction with the pantoprazole is probably the least. Later on, there were many papers which favored this view as well as which opposed this view. And post-hoc analysis of various trials later demonstrated the safety of co-administration of PPA, including omeprazole with aspirin and clopidogrel. And they concluded that there is no major adverse cardiac events in this combination. And particularly this caution trial, which came in NEJM in 2010, soon after, they found that in the subgroup where they received PPA along with the clopidogrel, there was a significant reduction in GA bleeding as well. So though definitely there's an interaction, theoretically there is a theoretical possibility, but ultimately if you analyze the data on a large basis, probably the risk is very minimal or negligible. Apart from this, it said that PPA actually can produce myocardial ischemia unrelated to drug interaction. It's demonstrated to reduce nitric acid release from the endothelium. Nitric acid is necessary for vasodilation. PPAs are reported to produce myopathy, dementia, community pneumonia, and of late there are some reports about development of diabetes mellitus, and ultimately there are papers which suggest an increased all-cause mortality with PPA. So where are we? The drug which we all use on a day-to-day basis having so many side effects, so many problems. So are they really unsafe? Well, this is a question which has been answered by various articles in various gastroenterology, cardiology, in various reputed journals, and they all said one thing in common. There are a lot of problems with the studies which actually pointed out these associations, these complications. Almost all these studies are observational studies, and it was not properly designed to conclude about a cause and effect. Like most of the time, the impact with the PPA was a subgroup analysis or a chance observation. And generally, patients with multiple comorbidities would receive more PPA more frequently. And these comorbidities, for example, a patient with a cardiac problem, cardiac failure, might be a diabetic, will be having a renal failure. So, and patient may be on aspirin. So patient will have multiple comorbidities, and these comorbidities can definitely act as confounding factors and can contribute to the various side effects. And as we all know, observational studies can only suggest an association between an exposure and an event, but it cannot establish a causation. And this is one famous criteria, Bradford-Hill criteria, which all these people do research and epidemiology. They all use this criteria to actually establish the cause and effect relationship when an association is blamed. So suppose you say that A can produce B and C, then we have to have certain criteria to be satisfied. And there are 9 parameters to be satisfied. This is actually interesting. That's why I'm going a little detail. So first, there should be a strength of association. So the data should be huge. The association should be high magnitude. So there should be a large number of patients where they found that PPA use can produce this particular problem. And there should be consistency in observations. So whatever you found, for example, PPA can produce renal failure, this data, the finding should be reproducible. It should be specific. There should be a temporality. For example, when you give a drug, suppose that drug produces hepatitis, so there is a temporality. The problem started after taking the drug. So this always happens after taking PPA. Biological gradient. So there should be a direct relationship with the dose, the duration of the PPA and outcome. Biological plausibility. There should be rational explanations, theoretical explanations to explain all these associations, all these side effects. The data should be coherent and should be backed by experimental data and analogy. Does it happen in the same setting? For example, PPAs produce acid suppression, and we say that acid suppression is responsible for enteric infection, more enteric infections. Does it happen with the ranitidine that can produce hypochlorhydria, acid suppression? Does it happen in the setting of pernicious anemia? There is no acid at all, but it is not happening. Studies are not showing that. So there is no analogy. So, and in many others, they actually demonstrated that if you look into various observation studies where PPAs were blamed for these huge side effects, in fact, it is not satisfying this Hill criteria. And then came in gastroenterology in 2019, this particular article, this paper, this is called COMPASS trial. where they looked into the safety of proton pump inhibitors. In this particular study, they used pantoprazole in patients receiving rivaroxaban or aspirin. So a 3-year trial, randomized control trial, pantoprazole versus placebo, almost 18,000 patients. And the endpoints were development of side effects related to PPA and all-cause mortality. And they found that, in fact, there is no major side effect. The mortality remained same, and there was only mild increase in enteric infections in PPA group. So this particular trial showed that, in a large number of patients, when they were followed for 3 years in a randomized population, PPAs were safe. And what about use in special situations like pregnancy? I'm sure all the gynecologists and we are all using PPA in pregnancy, particularly when they come with vomiting, when they have refractory heartburn. And the large meta-analysis came in American Journal of Gastroenterology, 7 papers, more than 1.3 lakh pregnant women. So 1,500 were exposed and the rest were not exposed. And they went and analyzed that there was no increase for spontaneous abortion, preterm delivery, or congenital malformation. And there's another study from Denmark where they used again PPA in more than 90,000 people. And such patients were followed up. The children were followed for 5 years, and they found that there is no increased, birth defects or congenital malformations. So FDA classified PPA as category B, except omeprazole. So omeprazole is category C. So category A and category B are safe drugs. Only omeprazole is category C. So the message is PPAs can be used in pregnancy when it is necessary on a safe basis. Similarly, in pediatrics, it's a little interesting. Again, FDA, esomeprazole is the only agent approved for children below 1 year. All other PPAs except pantoprazole can be used for children from the age of 1. So below 1, esomeprazole. Pantoprazole can be used only after 5 years. So this is what FDA says about PPA in pediatrics. So how do we go now? What is the way forward? So as I have shown, there's a lot of noise about the side effects of long-term PPA use. So we can at least say that the evidence is weak. We can, when there is a study, it can be interpreted in different ways. We can blame the statistics. We can have your own interpretation. We can have your own subgroup analysis. So whatever it is, many of the researchers agree that the evidence is weak and there are a lot of methodological flaws. But still, we can't ignore it. So we should not dismiss these observations. And definitely, we need to exercise caution and judgment before each prescription of PPA. So as the famous Hippocrates oath, we all learned, first do no harm, primum non cere. So whenever you prescribe, this is probably applicable to any drug. So make sure that this is prescribed for an appropriate indication, for an appropriate patient. You are using appropriate drugs for an appropriate duration, and give proper patient education. And for example, certain medications can have some side effects. If you start an antibiotic like amoxicillin, many a time it can produce abdominal cramps, diarrhea, some smell to the urine in the set. But this has to be instructed to the patient. Rifampicin can produce red urine. When you take bismuth, iron, it can produce tarry stools. So that has to be told to the patient. So patient has to be educated. And if you know that a particular drug can produce side effects, then patient needs to be followed up. For example, an antituberculous test can produce hepatitis. So after 1 week, you have to call back the patient and LFT has to be done. And PPA, now it's a fashion to use PPA for each and every GI symptoms. Vayru vedana, vayru kattunnu, kambikkunnu, gas, piles. എന്ത് പറഞ്ഞാലും എന്തിനും ഒരു PPA കൊടുക്കണം. I think that practice has to be definitely avoided. And it is not necessary to co-prescribe with all the drugs which you prescribe. As I have said, PPAs are recommended, or the guidelines only say that you have to prescribe along with NSAIDs, that in a high-risk population, patient above 65, patient who had ulcer before, who had ulcer complications before, or if you're prescribing NSAID along with an anticoagulant or steroid. Otherwise, it is not necessary to give PPA along with an NSAID in a young person. Please don't give PPA along with antibiotics. We all believe that antibiotics can produce gastritis. It is not. The dyspeptic symptoms happening because of the changes in the colonic bacteria. So antibiotics actually change the colonic biomass. So colonic metabolism is altered. That is the reason why you get a lot of gas, and so probably you need to supplement with probiotics, not PPA. And generally, any prescription in an IP will not be complete without a PPA, particularly patients in the ICU. You give injection pantoprazole twice daily. That is not necessary. And generally, the recommendation is always to start with a single dose, once daily. But all of us, including me, all tend to give a BD dose. That is not necessary. So actually, we are overdosing. And the other fashion is to use the combination. You know, very famous combinations, PPA with domperidone. It is very difficult to find a pure PPA. All these things have D or DSR. And you know what happens when you prescribe a DSR? Actually, that this contains 30 milligram domperidone. So if you're giving it BD, we are giving 60 milligram domperidone. If you're prescribing domperidone to a particular patient, you write 10 milligram TAD, isn't it? And domperidone, mind you, has got a lot of side effects. Actually, the American College of Gastroenterology recommends to take an ECG before starting domperidone. In fact, I didn't know about it. I mean, I came to know about it a couple of years back when I, did a internet search for one particular talk. So domperidone can produce arrhythmias, including torsades pointus. Domperidone can produce gynecomastia, lactanemia. So it can produce a lot of side effects. So domperidone and levosulprate, that is another L, PPAL. Levosulprate is actually a prokinase drug, and it's a psychotropic drug. Usually the dose is 25 milligram, but in a longer acting version, it is 75 milligram. So many times this drug is sometimes given twice daily, particularly in the morning. The patient may be driving a car, driving a vehicle. So 75 milligram of levosulprate, which has got sedative properties, is given along with the PPA. And another problem with this combination is, unnecessary side effects. And many times it is not necessary. If you're treating GERD, none of the, bodies, be it American College of Gastroenterology, Asian consensus, European consensus, nobody is recommending prokinetic in treating PPA. It is not necessary for ulcer disease. So why are you prescribing? No, I'm just saying that, even we are all doing that, gastroenterologists are doing that, but this actually, we have to definitely go back and check our prescription pattern and unnecessarily prolong therapy. And it is mandatory to monitor OP as well as IP prescriptions. And another thing is prescription from different departments and consultants. We face this problem in a hospital like ours, where a patient comes to a hospital, patient may be having a cardiac problem, patient may be having a back pain, patient may be consulting a gastroenterologist, and patient may be above consulting a physician. So orthopedician prescribes an analgesic given PPA. Cardiologist has already started a PPA along with an aspirin. Gastro has no other drug to give but a PPA. And many a time this patient will be taking one pantoprazole, rabiprazole, probably another rabiprazole from different doctors without knowing that he is taking it. So we have to spend some time and look into the prescriptions and see whether there is multiplication. And apart from all these things, they may be having these medicines, gas in a medicine stock at. So, and ultimately we end up in giving very high doses of PPA. And it's not necessary to stop prescribing PPA in CLD and CKD, but exercise caution. And there is an Indian recommendation, a SPERT committee recommendation. There are a lot of side effects like hypocalcemia, hypomagnesemia, B12 deficiency. What they say is the recommendations, some of the recommendations are, one is avoid long-term prescription of PPA, particularly in functional dyspepsia and irritable bowel syndrome. In fact, in irritable bowel syndrome, there is no role for PPA. The treatment is totally different. Functional dyspepsia, only a short course. If the patient is not improving, don't give PPA. It is not necessary to monitor calcium, magnesium, iron, etc. And it is not necessary to recommend additional supplements. Only thing is you have to be cautious, as I said, when you prescribe in patients with comorbidities and old age. So to summarize, though PPA have a lot of side effects mentioned in literature, as we all know, they are very useful drugs. They have actually revolutionized the treatment of GERD as well as ulcer disease. Very widely used for similar reasons, and these problems are quite common in fact. But unfortunately, it's often misused overused, and abused. And we have raised concerns about various side effects, but at least as of now, the evidence is not very strong. And there is enough data to show that they are safe when used appropriately. So the bottom line is you have to have a common sense approach, a balanced approach. You have to use PPI whenever there is a clear-cut indication. But mind you, try to give the lowest effective dose for the shortest period of time. Thank you.
Thank you, Dr. Benoy. I think that was a very lucid but elaborate talk on the use, the misuse and overuse of PPIs as a class of drugs. I think all of us need to imbibe what he has said here and regulate ourselves in our prescriptions also. We need to reassess what we write to our patients. PPIs were generally thought to be very safe. So we all use it left, right, and center. Now I think with this talk, we have to be a little more cautious. Though there were reports earlier, I think most of us tend to ignore, and we think that PPIs are a must for every prescription. So I will open up the topic for discussion. And, you can unmute, ask your questions, and mute again.
Benoy, Alexia, you said the process of pseudomembranous colitis. For how long we should use this PPI inhibitor to get pseudomembranous colitis?
Well, there is no data like how long you should use or what is the minimum period of PPI use which can produce pseudomembranous colitis. The thing is long-term use. Long-term use means usage of PPI for many months together can lead to
No.
Can you repeat, Benoy? You have.
pseudomembranous colitis. The interesting thing is nowadays we are seeing toxin assay. We are getting more cases, and many of these patients are actually hospitalized probably. Am I audible?
Not
Yeah,
clear.
you're audible now.
Okay. Did you hear me the initial part?
No, initial part it was a little.
Okay, basically there is no cutoff duration for PPI to produce, PMC, nothing like that. But in any situation, if you are using it for months together, it produces acid suppression in the stomach and can, risk your patient to develop PMC. The thing is, PMC doesn't mean that antibiotic-induced diarrhea always. It can happen in other patients also. And we are picking up more cases primarily because we are more positive in looking for toxins now. Any hospitalized patient developing diarrhea, one of the strong varieties would be a pseudomembranous colitis.
Yes, Benoy. Thank you. Benoy, അപ്പം ചോദിച്ചോട്ടെ ഈ ആസ്പിരിനും ക്ലോപ്പിലിറ്റൊക്കെ കഴിക്കുന്ന ആളുകൾക്ക് is it indicated? Definitely. പറഞ്ഞനുസരിച്ച് കൊടുക്കണോ?
It is indicated. It is indicated along with aspirin. And though initially there was a lot of noise with this interaction, definitely there is an interaction, clopidogrel omeprazole interaction on this, but that interaction is very limited with the pantoprazole. So you can safely use pantoprazole. Now, if you are using one PPI, better to use pantoprazole along with aspirin and clopidogrel. That is number one. Even they have shown that omeprazole also can be used. So it can be used, but it is not necessary to use for NSAIDs in all cases. If ചെറിയ പ്രായത്തിലുള്ള ഇപ്പം നമ്മളെപ്പോലുള്ള ആൾക്കാർക്ക് suppose you are taking Brufen, ഇത് വേണ്ട അത്രേ ഉള്ളൂ. That is what they recommend, but you are not using NSAIDs for a long time basis. So safely, namakkanna judicious ആയിട്ട് we can use it for a short time basis. There's no harm. Most of the side effects are happening in patients who have long time PP. Not. I think PPI use more important. Hello?
Yes,
Am I audible now? What I
yes,
wanted to highlight is the use of combination. നമ്മളെല്ലാം ഉപയോഗിക്കുന്നുണ്ട്, ഞാനും ഉപയോഗിക്കാറുണ്ട്. പക്ഷേ many a time we actually ended up giving overdose of particularly drugs like domperidone. Many time ഈ domperidone ആവശ്യമില്ല. ഈ ബ്ലോട്ടിങ് നമ്മൾ domperidone ഉപയോഗിക്കുന്ന ഗ്യാസ് ഉണ്ട്, എംബക്കം ഉണ്ട്, ബെൽച്ചിങ് ഉണ്ട്. It's indicated when there is vomiting. അല്ലാതെ ഉള്ള ഈ ബ്ലോട്ട്, ഗ്യാസ്, കമ്പനം അതൊന്നും there is some role for prokinetic. You can try it for some time. For example, ഉണ്ടെങ്കിൽ അങ്ങനെയൊക്കെയുള്ള സിറ്റുവേഷനിൽ. Otherwise, these kind of things are actually functional dyspepsias, where you may have to correct the upper story. അങ്ങനെ വരുമ്പോൾ you may tend to use drugs like now.
Benoy ഇടയ്ക്ക് കട്ട് ആവുന്നുണ്ട്.
So you can continue.
Benoy ഇടയ്ക്ക് കട്ട് ആവുന്നുണ്ട്.
എന്റെ ഓഡിയോയുടെ പ്രശ്നമുണ്ടല്ലേ?
ഓഡിയോ
ഹലോ,
ടോക്കിന്റെ സമയത്ത്
പിന്നെ ഒരു ചോദ്യം കൂടി. ബിനോയ് കേൾക്കാവോ? ബിനോയ്
കേൾക്കാം, പറഞ്ഞു.
ഹലോ, പറഞ്ഞു.
പിന്നെ GPSന്റെ മുമ്പിൽ ഏറ്റവും വരുന്ന കൂടുതൽ സിംറ്റംസ് GA തന്നെയാണല്ലോ. ബ്ലോട്ടിങ്, ഇറക്ടേഷൻസ്, ഡിസ്പെപ്സിയ. അപ്പൊ സ്വാഭാവികമായിട്ടും നമ്മുടെ പേനത്തുമ്പിൽ നിന്നും ആദ്യം ഒഴുകി വരുന്നത് PPA തന്നെയാണ്. അപ്പൊ അത് എഴുതുന്നതിന് മുമ്പ് എന്താണ് എഴുതാതിരിക്കാനൊരു അഡ്വൈസ് നമ്മൾ കൊടുക്കാൻ പറ്റുന്നത്? ഈ സിംറ്റംസ് അഡ്രസ് ചെയ്യാതെ പോകാൻ പാടില്ല.
അങ്ങനെയല്ലേ, എഴുതണ്ടെന്നല്ല. ഇറ്റ്സ് നോട്ട് ദാറ്റ് യു ഷുഡ് നോട്ട് റൈറ്റ്. സോ ബേസിക്കലി എക്സാക്ട്ലി ബിഫോർ വി സ്റ്റാർട്ട് പ്രിസ്ക്രൈബ് PPA രണ്ട് മൂന്ന് കാര്യങ്ങൾ ഞാൻ ഇപ്പൊ പർപ്പസ്ഫുള്ളി ഐ ഓൾവേസ് ലുക്ക് ഇൻ ടു വേരിയസ് അതർ പ്രിസ്ക്രിപ്ഷൻ. മെനി എ ടൈം ഈവൻ എന്റെ യൂണിറ്റിൽ നിന്ന് ഡിസ്ചാർജ് ചെയ്ത പേഷ്യൻസിന് പോലും ഇറ്റ്സ് ലൈക്ക് സംബഡി ഹാസ് കം വിത്ത് വേരിയസൽ ബ്ലീഡ്, സിറോസിസ് ഉണ്ടായി, വേരിയസൽ ബ്ലീഡ് ഉണ്ടായി. ആ പേഷ്യന്റെ പ്രിസ്ക്രിപ്ഷനകത്ത് പാൻഡോസിഡ് അല്ലെങ്കിൽ പാൻഡോപ്പസോൾ ടോയ്സ് ഡെയിലി ആൻഡ് താഴെ വേറൊരു എസ്എംഎപ്പസോൾ ടോയ്സ് ഡെയിലി. പലപ്പോഴും സംഭവിക്കുന്ന പല ഡോക്ടേഴ്സ് വന്ന്, പല കൺസൾട്ടൻസ് വന്ന് കാണും, even if it is not, നമ്മുടെ മെയിൻ ഫയലോട്ട് എഴുതിയില്ലെങ്കിലും സിസ്റ്റേഴ്സ് മൈറ്റ് ഗീവ് ദ ഇഞ്ചക്ഷൻ. അപ്പൊ അങ്ങനെയൊക്കെ വരുമ്പോഴേക്കും വി മൈറ്റ് എൻഡ് അപ്പ് ഇൻ ഗിവിംഗ് അൺനെസസറിലി. സോ ഇറ്റ് ഹാസ് ബിക്കം സജസ്റ്റ് ഒരു മസ്റ്റ് പോലെയായി. അങ്ങനെ ആവരുതെന്നുള്ളതാണ് മെയിൻ തിങ്. ആൻഡ് ടു അഡ്രസ് യുവർ ക്വസ്റ്റ്യൻ, കമറ്റന്റെ ക്വസ്റ്റ്യൻ പറയുകയാണെങ്കിൽ ഡെഫിനറ്റ്ലി വി ക്യാൻ സ്റ്റാർട്ട് വിത്ത് എ PPA ബിക്കോസ് ഇറ്റ്സ് എ സേഫ് ഡ്രഗ്. ഇങ്ങനെ ഒത്തിരി ബഹളങ്ങൾ ഉണ്ടെന്ന് പറഞ്ഞാലും ഇറ്റ്സ് സേഫർ ദാൻ ഒരു എംപെരിക്കലായിട്ട് നമ്മൾ മരുന്ന് കൊടുക്കുകയാണെങ്കിൽ ഇറ്റ്സ് സേഫർ ദാൻ മെനി അതർ ഡ്രഗ്സ്. But probably you restrict yourself to a short course. If patient നമ്മൾ കുറച്ചാൾ കൊടുക്കുക, then tell him this is one drug which you can take, but if you are not improving, well, please come back. നമുക്ക് വേറെ അടുത്ത മരുന്നിനെ കുറിച്ച് ആലോചിക്കേണ്ടി വരും. അപ്പോൾ IBS എന്ന് പറയുന്നൊരു അവസ്ഥയ്ക്ക്, ഇപ്പോൾ ഫോർ എക്സാമ്പിൾ IBS is something where you get an abdominal pain, diarrhea, constipation, അവർക്ക് കുറച്ച് ഗ്യാസ് കാണും, അവർക്ക് കുറച്ച് ബൾക്കിങ് കാണും, അതെല്ലാം ഉണ്ട്. അങ്ങനെയുള്ള ആൾക്കാർക്ക് there is no indication for a PPA. So probably കുറച്ചുകൂടെ നമ്മളൊന്ന് ക്രിസ്റ്റലൈസ് ചെയ്യുവാണെങ്കിൽ we can avoid many of our prescriptions. ഒരു പേഷ്യന്റ് രണ്ട് മൂന്ന് ഡോക്ടേഴ്സിനെ കാണുന്ന ഒരു സ്ഥലത്ത് പ്ലീസ് ഗോ ത്രൂ ദ അതർ ഡോക്ടേഴ്സ് പ്രിസ്ക്രിപ്ഷൻ. ഇറ്റ്സ് നോട്ട് ഈസി. തിരക്കുള്ള സമയത്ത് പലപ്പോഴും എളുപ്പമായിരിക്കില്ല, മറ്റേ ആൾ എഴുതി എന്താണെന്ന് മനസ്സിലാവില്ല, ട്രേഡ് നെയിംസ് ഉണ്ട്, ദെൻ യു ഹാവ് ടു അത് നോക്കണം. അങ്ങനെ വരുമ്പോൾ യു ആക്ച്വലി ഇറ്റ്സ് എ വേസ്റ്റ് ഓഫ് ടൈം, ബട്ട് സംതിങ് ലൈക്ക് ദാറ്റ് ഹാസ് ടു ബി ഡൺ.
Any difference in the duration of action of the PPI? Supposing we use PPIs with a shorter duration of action.
Yeah, there are some differences. Actually, what they say is rabiprazole is supposed to be one of the fastest acting, and that Tmax are better. And similarly, omeprazole is a little more longer than dexlansoprazole, the newest one. Other interesting mechanism. Actually, this has two releases. Most of these PPAs are released in the duodenum. They are not metabolized in the stomach. Stomachil നേരെ പോയി duodenത്തിൽ പോകും. ഈ dexlansoprazole രണ്ട് മെക്കാനിസംസ് ഉണ്ട്. One immediate to 25 to 30% is released in the duodenum, and the rest is released in the small intestine. So ഈ ഫുഡുമായിട്ടുള്ള ഇത് it has to be given before food എന്നുള്ളത് it's not applicable to dexlansoprazole. Many times it is not easy. ആൾക്കാർ മറന്നു പോകും. Otherwise, even if there are some minor differences in the pharmacokinetics, ultimately if you translate into the endpoints, for example ulcer healing, അല്ലെങ്കിൽ clinical response to GRD, all fare equally. So minor difference in the pharmacokinetics doesn't actually translate into the clinical results. And which one is the best PPA? All PPAs are probably equally good. Your PPA, you select your PPA and use it.
The short-term treatment is 14 days.
Other FDA or OTC over the counter without a prescription. Yes, sir, you're right.
14 days patient therapeutic effect 10 days. Can that patient be satisfied?
Illa. അതുകൊണ്ടാണല്ലോ ആൾക്കാർ വീണ്ടും misuse ചെയ്യുന്നത്. See, the thing is that is illa sir, I'll come to that. That is recommendation as an OTC. With a doctor's prescription, you can definitely use it for a longer period. Either you have to give it, for example, if there is GERD, gastroesophageal reflux disease, this has to be given for 3 months for healing. If it is a gastric ulcer or duodenal ulcer, the duration is, if there is H. pylori, it has to be given for, along with the antibiotic, 2 weeks and another 4 weeks. So that is the duration. So another indication, but OTC, nobody has, if you are just going and buying it for a gas, nobody has diagnosed GERD or ulcer for him. So we are, the person is empirically taking the medicine. For prescription, there is finite duration, but OTC, it is only for OTC, over the counter.
There are 2 questions in the chat box. Can we give sucralfate along with PPI? Second one is PPI use in children.
Well, the first question, you can give sucralfate along with PPA, no problems. But when you give sucralfate, the most important thing is, sucralfate is something which coats. Sucralfate in a mechanism is a proteinaceous material which coats over the ulcer, which coats over the mucosa, which coats over the injured epithelium. So when you give a drug, sometimes it coats over the drug. But drug in the absorption impair. So when you are giving sucralfate, either it has to be given 2 hours before or 2 hours after giving the drug. Sucralfate otherwise is not absorbed, so it's not going to affect the systemic bioavailability, but it can affect the absorption of the medicine. So this is important. Sucralfate can be given. And PPA use in children, there was a slide about that. PPAs are safe in children. Though it's not widely used, it's given or it is indicated if there is a clear-cut indication. So as I said, esomeprazole can be used in all children, including infants less than 1 year. Pantoprazole can be used after the age of 5 years. The rest can be used from 1 year onwards. Rabiprazole, omeprazole, all those PPAs. Hello?
Yes, Keto.
What should be the dose of PPAs in children?
Dose, actually, you have to calculate. Often it's given. There are some recommendations. Esomeprazole, what they say is less than 1 year. I think it's 5 milligram. But I don't know. We use it in children because lansoprazole in preparation and something called junior lansoprazole. It is 15 milligram. But syrup form is available. So how do you give it to children? As I said initially, we cannot give. We should not break the tablet, because once you break the tablet, it goes to the stomach, and in the acid, it is damaged. So drug in the absorption. So for children, what they say is there are 2 types of tablets. One is an entry coated. You have seen only tablet, entry coated tablet. Then there are capsules. Actually, if you break the capsules, it contains a lot of granules, small granules. So these granules can be sprinkled over a soup or juice. Sprinkle spoon so that child will swallow it. Similarly, rice tube arti feeding. Granules granules coating granules coating granules mechanism stomach gelatin capsule release and the granules to. So similarly, if you want to give it through the rice tube, the same mechanism. So tablet And one of the companies actually marketed rabiprazole in granule form. So they are not marketing it now.
Okay, Benoy, what about H2 blockers versus PPA?
PPA always cause, I mean, if you look into because PPA is the final common path. If you want to suppress acid, give PPA. H2 receptor blockers in a indication, there is something called a nocturnal acid breakthrough. Due to some curious mechanisms, the nocturnal acid suppression is probably less with the PPA. Exact mechanism or a topic in nocturnal acid breakthrough, and many people get sometimes nocturnal symptoms also. It's not always a reflex. So in such cases, exactly. That is the only situation you give a ranitidine in the night. To somehow H2 receptor blockers are superior to PPA in suppressing this nocturnal acid breakthrough. Otherwise, nocturnal symptoms they need not even get symptoms. Either suppose there is a GRD which is not getting healed, then they may not get nocturnal symptoms. But if you do a 24-hour pH metry, refractory heartburn little more research suppose the patient is not responding to a PPA, ultimately you have to make sure that it is heartburn, acid. It can be due to many other reasons. So do a pH metry, and then you demonstrate nocturnal high acid pH in the esophagus, even without symptom. Then that is called nocturnal acid breakthrough. Adina ranitidine better. Otherwise, there is no point in combining these two for a better efficacy. Omeprazole start the patient better ranitidine. That is not necessary. And ranitidine, if you ask me, the efficacy is around 70 to 80% in ulcer healing, 70% at most. Antacids in 50 to 60%. We take just antacids alone. And omeprazole PPA group is more than 90-95%. That's under comparison.
Hiatus hernia PPA stroke role.
Yeah, hiatus hernia problem. Hiatus hernia problem hiatus hernia is a mechanical problem. We cannot treat the actual problem, but we can treat the reflex. Reflex treat
symptom control.
Suppose symptom control, exactly.
Is there any contraindication for PPA in chronic liver disease?
As of now, there is no contraindication. But having said that, generally what we used to do is under all CLD patients, cirrhotics and all prescription PPA. They had bleed. For example, varicose rupture. Varices rupture PPA. And at that time, there was a theory called corrosive theory. Either acid reflex on the esophagitis corrosion on the varices concept. But now it is proved that it is not happening at all. So varices are rupturing just because of the pressure. Intravarious pressure liver dysfunction. So there is no role for giving a PPA to prevent varices rupture. Number one. Number two, the only situation where it is given, of course, if there is an ulcer, GRD symptoms bandage sclerotherapy a patient with a various it comes, we do a banding. This banding, post banding, they can get ulcers, esophageal ulcers. And banding, the varices is fused, varices undergo necrosis, mucosa slough of it go, it leaves behind an ulcer. Ulcer helium fibrosis fibrosis varices constricted. That's how it works. So there is in the natural history of shrinking of varices, there is an ulcer formation. So this ulcer bleed is actually a very dramatic, very difficult to control situation. And there is some evidence to say that if we give PPA, at least for 2 to 3 weeks, the ulcer formation might come down. So generally, we sucralfatum PPA, though the evidence is very weak. Otherwise, whenever there is an indication, you can prescribe a patient SBP or renal failure. Generally, we tend to avoid. That's the standard. Renal failure, SBP, spontaneous bacterial peritonitis.
One question.
If SBP then we tend to avoid PPI unless it is really indicated.
In our place, we get a lot of cases of leptospirosis. So most of the time, when the patient comes with fever and severe body ache, we sometimes empirically treat them with the doxycycline. So can we use rabiprazole along with the doxycycline to prevent esophagitis?
the only way is to educate the patient. One is try IV doxycycline. Doxycycline problem and it produces a contact, something called pill esophagitis. Doxycycline tablet out sticky esophagitis. So basically, you have to educate the patient to drink a lot of water. Usually, mostly this is prescribed by gynecologist and dermatologist. Sorry, most doxycycline. Doxycycline is used for PID, pelvic inflammatory disease, and dermatologists use it. Just because they are using it more frequently, their patient develop anti-leptos seasonal prophylaxis. So, thing is, doxycycline patient should be educated to drink at least 2 glasses of water. 2 glasses of water, doxycycline, another 2 glasses of water, and don't lie down for half an hour at least. So this is primarily, and this is not going to prevent it. And ICU patients, it is not possible. Lepto patient, myalgia patient may not sit up and they may be having vomiting. So such cases, now we used to give IV doxycycline. In fact, one of our classmates, Dr. Kamath might be knowing, Biju John was an classmate and he works in a PSC. Many years back, chikungunya, and it was a prophylaxis, doxycycline. So them OP patients he also started taking doxycycline. And one fine day he took a doxycycline tablet. He started getting pain. 3 days on Sunday he came for an endoscopy, and I could see the tablet inside the ulcer, and it was almost esophageal perforation. With a lot of difficulty and tablet, I was very scared I will create a perforation, but luckily it came off.
Tablet form causes esophagitis or capsule form?
Tablet risk on the tablet ആണ് കൂടുതൽ. But oral, when this happens with all other drugs, potassium chloride tablet ഉണ്ട്, നമ്മുടെ ഈ സാധനം ഉണ്ടല്ലോ alendronate group, even NSAIDs can produce it. For that matter, all medications you should advise the patient to take in the right posture with a lot of water.
This clopidogrel and rabiprazole, does it have interaction?
Clopidogrel and rabiprazole has only very minor interaction. Rabiprazole and pantoprazole has got another cytochrome P50 pathway. You can use rabiprazole.
You can use rabiprazole or
pantoprazole. So if you ask me, the most strong recommendation is for pantoprazole.
One more question you have already discussed is about sucralfate and proton ion inhibitors. In undergraduate days, we have taught that the sucralfate action, for sucralfate action, you need an acid media.
Yeah.
And otherwise, the sucralfate
that is true. Sucralfate, it has to be broken down. Sucral aluminum sulfate. Yeah, you are right.
Acts better in an acid media.
Acts better in an acid media.
There is
a theoretical possibility. You are right. You have pointed out that. But evidence or data like combination can actually reduce the bioavailability of sucralfate, efficacy of sucralfate comes down. We are more worried about the efficacy of other drugs.
Instead of using proton pump inhibitors IV, sucralfate.
Sucralfate, yeah, there are trials.
Is better to prevent stress ulcers.
Views on the sucralfate or even ranitidine can actually prevent. Though, if you look into stress ulcer marker, so there are 2 endpoints. One, you are trying to prevent stress ulcer, and again at the cost of developing probably aspiration and increased respiratory infection. That is what is happening in the ICU. So you have to trade between these 2. Stress ulcer prevention is better with PPI, but well, if you look into the pneumonia data, That is better with H2 receptor blocker or even sucralfate.
Which is the correct disease?
Voice break. Sorry?
What is the indication, correct indication of using sucralfate?
Correct indication.
Sucralfate
If you ask me,
indication.
Correct indication, or it's like a soothing agent. It's in fact not found to heal anything. It's only a coating agent. It's a mucosal coating agent. It's only a barrier. There is no definite indication for sucralfate, in fact. So it just works like even inferior to antacids in reflux. By itself, it doesn't heal ulcers. So we use it in situations like severe mucosal disease or co-therapy can be used.
I think gastric ulcer to prevent
Hello.
a large gastric ulcer, example, large.
It's getting break.
If you are using it,
Come
on. Hello.
No.
If you are using it in a large gastric ulcer, it can coat the ulcer floor and protect the ulcer from further bleeding, etc. Is it correct?
It is not correct actually. Wishful thinking. It coats definitely, but the ulcer healing with sucralfate alone. So you attack the ulcer in different ways. Suppose the ulcer is due to Helicobacter pylori, you give Helicobacter pylori treatment. Along with you suppress the acid. Acid because it's acid peptic disease, isn't it? Acid it digests the pepsinogen. So that's correct. And to an extent, this coating might also help. And there are antacids also reduce the acid, but well, both have a different mechanism of action. And for a single agent, there is no role. Hello.
The NSAID aspirin. Hello. Just one point I want to add. NSAID, which produces gastric ulcer, peptic ulcer, is not due to the direct effect.
It is not due to the direct
effect.
Yeah, true.
Mucosa.
Yeah, absolutely right.
Prostaglandin inhibition.
Correct. Yeah.
Inhibition.
That is true.
So it means even a small prostaglandin inhibition, small ecospirin 75 milligram can produce a duodenal ulcer, peptic ulcer.
Exactly.
It's not dose dependent.
But
and there is no use for an enteric-coated form.
Exactly. Aspirin, when you give aspirin sometimes can produce ulcers in the rectum. NSAIDs can produce ulcers in the rectum, in the right colon. Even IV injection overrun ulcer. So this is a systemic effect. But there is some local irritant effects on it, though it's very minor.
Okay, Sajesh.
We thank Dr. Benoy for this wonderful talk which you have given, and also for the discussion, bearing with us throughout this discussion.
It was a joy and pleasure to interact, because all known faces. It's like a chat or a peg or a couple of beers. We miss all met that. Unfortunately, sitting in our sitting rooms and looking into the TV, we enjoy new way of life, isn't it?
We miss the Ghana.
I was just thinking if there were more of us now, if this in between the numbers had gone up, if everybody was here asking questions, no tirula.
Anyway, it's always nice to have interaction. Talk
That's correct.
That is very good.
Either
It was very
That,
nice.
Before we wind up, also Marcos sir and our senior gynecologists are there. Agnes madam and Annie madam and that I will.
Sir, mute. Marcos sir, എന്തെങ്കിലും പറയുന്നോ? Mute, unmute ചെയ്യ്. Unmute ചെയ്യ്. Sir, mute.
Madam.
It was a very nice talk, Dr. Benoy. Very, very nice. Especially that part about multiple consultants writing tablets, which sometimes we cannot read. And the nurses definitely will give because they think it's an issue with personality or ego. So I think it has to be stressed more and more among doctors about this topic. Should not be really written too much. Then as for doxycycline and even drugs which are known to cause irritation, instruction giving to the patient when we write prescription is very important. We're all taught, but we don't have time and we don't do it. When we give doxycycline and we give for even longer periods, I haven't had patients complaining and I don't write anything with it except a B complex. And I've been noting that they come back with this complaint. So it is the instruction about how to take it, when to take it, which the government of India now is telling that we should include in the prescription. I hope IMA is taking that up. Prescription writing has to improve. It has to be in the proper format in every hospital. So PI being written, and this is one drug that in the OT and the recovery, the nurses will say, "Madam, don't you want to write that?" Usually, very limited is needed. This talk has been very enlightening and very reassuring because I look like somebody who doesn't write that. So, thank you, Dr.
Thank you, ma'am.